afternoon, everybody. My name is Dr. Limael Rodriguez. I'm a third-year general surgery resident at the St. Luke's Memorial Hospital in Ponce, Puerto Rico. It's been a pleasure to be here. We've been here the last 2 days enjoying Dubai. Here is my chairman. He also made the trip, and he's sitting in the back, Dr. Bolaños, if you haven't met him. Our study is titled Clinical Implications of HIDA, cholescintigraphy, and ultrasound in the diagnosis of acute cholecystitis. Really, the background for this study was that I noticed that we had a certain protocol for employing the HIDA scan, which really was done once we had admitted the patient. And then I wanted to follow up these patients and see if there was an effect on outcomes employing this protocol. I have no disclosures. The background of acute cholecystitis, it's an important diagnosis in the spectrum of biliary tract disease. It occurs in about 20% of patients with biliary colic. Acalculous cholecystitis accounts for 5 to 15% of all cases. So the majority of patients that are presenting with acute cholecystitis have a component of gallstone disease as well in their presentation. Risk factors for gallstone disease overall: increased age, obesity, metabolic syndrome, Hispanic ethnicity. These are all significant risk factors that I found cited in literature. We're coming in from Puerto Rico, which is primarily a Hispanic society population. Our population is a little bit more than 3.5 million. I was interested to find that in Dubai we have almost double the population of Dubai. Obesity is an epidemic on our island. We're the second, I guess you can say, fattest city that obesity is rampant in the world. So about 40% of the population meets the criteria for obesity, and of these 40%, 45% of men and 42% of women have a metabolic syndrome component. And although I couldn't find a specific study that addresses cholecystitis in our population, you can suspect that prevalence of gallstone disease is increased in our society. So with that said, acute cholecystitis, over the last recent years, people have noticed, researchers have noticed that there is, although it's a very common diagnosis, diagnostic criteria really had not been established. You see this clinically and you treat it accordingly, but diagnostic criteria were not available. I really like this, the guidelines produced by the Tokyo group, where the main take-home message here is that in order to make a definite diagnosis of acute cholecystitis, they recommend 3 components. Not only should you have a local sign of inflammation, Murphy's sign, right upper quadrant plane, you should also have systemic signs, such as fever, elevated white blood cell count. They also mentioned CRP. We didn't study CRP's efficacy in this situation. But in the end, what I highlighted in red is to make the definite diagnosis, you should have a component of A and B. And then C is that you should confirm the test with an imaging modality, whether it's CT, whether it's ultrasound, MRI, HIDA scan. They have different modalities, but you should confirm the diagnosis with an imaging study. So in our institution, we have 2 main studies that we employ when we're in this setting, in the setting of acute cholecystitis. To give you a little background on ultrasound historically is the best initial test. From all the literature review that I found, the sensitivity ranges anywhere from 24 to 97%. I actually found one paper that the sonographic Murphy, the physical exam finding, was more sensitive for acute cholecystitis than the actual imaging. The specificity is anywhere from 71 to 93%, and then its limitations fall in the setting of acalculous cholecystitis, detection of mild edema, and or pericholcystic fluid, which I found was strict criteria. And there's a high number of false negatives when the wall inflammation is of a lesser degree, either by the imaging that's not capturing the inflammation, or the operator is not catching the level of inflammation. So in the end, one of the most important components is that it's operator dependent. Then the HIDA scan background. Overall, this is the best study that's available. It's got a sensitivity that ranges anywhere from 68 to 100%, and a specificity anywhere from 87 to 100%. I think that its limitations fall is that it's dependent on cystic duct obstruction for a positive test. To give you an example, in our study, 4 patients had false positive tests So the HIDA scan did capture cystic duct obstruction and released said that this was a positive exam for acute cholecystitis, but the final pathology was chronic cholecystitis. So I think it did its job in finding the cystic duct obstruction, but the pathology didn't correlate with acute cholecystitis. And then false negatives in the literature, in the setting of an acalculous cholecystitis, when the duct remains patent, can happen, and patients that are fasting for more than 24 hours have a tendency to have a false negative exam. So getting to our study, we did a cross-sectional study from January 2013 to July 2014. We looked at all patients that were admitted through ER with the suspected diagnosis of acute cholecystitis. In the end, we found 117 patients admitted. 91% of these patients underwent official sonogram pre-admission in the ER setting, and then 29% of the patients underwent HIDA scan post-admission. We admitted the patient, we waited for the HIDA scan to give us a result, and from there we made a clinical decision. And in the end, all these patients all underwent cholecystectomy and pathologic staging prior to discharge. Exclusion criteria or patients with pancreatitis or cholangitis, patients with elective surgery were not the patient population that we were looking for, and then patients without imaging studies were also excluded from our study. The purpose was simple. We wanted to evaluate the performance of ultrasound versus HIDA scan in the diagnosis of acute cholecystitis when compared to final pathologic staging. And then we also wanted, personally, I wanted to evaluate if the delayed HIDA scan, the way that we would admit the patient and post-admission do a HIDA scan, we wanted to see if that affected outcomes, length of stay, time to OR, costs, etc. And then the primary endpoint is that we wanted to see if we could establish a clinical model for predicting acute cholecystitis that would lower the threshold to perform HIDA scan in a more acute setting, which we prefer it to be in the ER setting. So here's the baseline characteristics of here's my results. Mean age was about 44 years old. Women were the majority of the patients. Mean BMI was 30, which was expected in our population. White blood cell count overall was 13, plus or minus 5.3, the standard deviation. Lipase, AST, ALT, bilirubin levels, as you see here, they were not significantly elevated overall in our study. In terms of laparoscopic versus open technique, 82% of the patients underwent laparoscopic technique, and 18% underwent open. And then of the open, 71% or 15 of the 21 patients were lap converted to open, which was really related to a difficult anatomy that we had to convert to make it a safer procedure for the patient. Overall final pathology, this is a frequency chart of all the diagnoses that we found in the final pathology. And when I break it down in red, what I finally found was that chronic cholecystitis was the main diagnosis in 61% of the patients, and acute cholecystitis was found in 39% of our patients. With acalculous cholecystitis, it was found as a subset of acute cholecystitis was 6.7%, which was consistent with literature. Frequency of the diagnosis made by pathology report, and these can overlap each other. Cholelithiasis was found in 77% of the patients, chronic cholecystitis in 79.2% of the patients, and acute cholecystitis in 39, almost 40% of the patients. So now getting to the specific imaging modality. The frequency of diagnosis made by ultrasound, cholelithiasis was found in 74.5% of the patients. Basically, it almost always captured the gallstones. Acute cholecystitis was detected in 22.6% of the patients, so it was underdiagnosing acute cholecystitis. Chronic cholecystitis was underdiagnosed. It was captured in 2.8% of the patients. Here is my comparison of ultrasound versus the final pathology report. And when we break down the data, the sensitivity of ultrasound in our institution was 26.2%, which was in the lower tier of what I found in the literature, and the specificity was 79.7%. And then obviously its main fault was the high number of false negatives that we found, that we discovered on final pathology report. Here we get to the HIDA scan, the frequency of diagnosis made by HIDA scan, acute cholecystitis. It was diagnosed in 50% of the patients. Chronic cholecystitis was underdiagnosed, and dyskinesia, biliary dyskinesia, having an ejection fraction less than 35%, was diagnosed in 44% of the patients. The comparison of HIDA with final pathology report revealed that the sensitivity in our institution was 86.7%, and the specificity 79%, which obviously suggests that this was a superior, at least in our institution, was the superior exam for detecting a HIDA scan. As you can see here in the false negative, I don't have a pointer, but as I mentioned before, there was 4 false positives. They were all in the setting of chronic cholecystitis in final pathology report that were read as false positives, but it still captured that there was a cystic duct obstruction. Outcomes. I just want to get to the point here. This is where the length of stay, admission to surgery, surgery to discharge. Overall, the length of stay for patients that received the HIDA scan with the protocol that we employ at the moment stayed an average of 2.4 days more in the hospital. The admission to surgery was 1.7 days more for the patients that we employed the HIDA scan in. The surgery to discharge, overall, both treatment groups left the hospital once the operation was done at the similar rate. Age, there was a trend towards us employing the HIDA scan in an older population, and the cost overall doubled in the group that got a HIDA scan, and this was primarily due to the days, the extra days that the patient was staying in the hospital. Finally, I'm getting to the meat of my presentation, the multivariate analysis for acute cholecystitis. I found that in my data set, everything out of all the terms of all the clinical features, age, glucose, and white blood cell counts that were elevated were all associated with a significant odds ratio that were significant for acute cholecystitis. In red, I highlight that patients with acute cholecystitis had a higher mean ALP level than patients without acute cholecystitis, but we only captured 74 of 117 patients had ALP actually carried out, and so we didn't include this in our multivariate analysis, but this could also be a factor that was significant. I also looked at multivariate analysis for conversion to open, and age and white blood cell count held up as positive, had an odds ratio that was significant for conversions to open. There was an association with glucose that was not significant, but the odds ratio of 3.28 appeared clinically significant, and the statistician, he felt that this may be due to a lack of power, and if we increase our power and get a higher population, maybe we'll find that the glucose does have a statistically significant odds ratio. Then we get to where I want to make the clinical model, and the statistician, he started making advanced analysis, and basically what he used was the regression analysis, and he used the regression coefficient, to devise a score using glucose, age, and white blood cell counts, the factors that we found in our study. And as the score goes up, glucose got 1.5, age got 1 point, and white blood cells got 1 point. As the score goes up, as we see here, there's a higher likelihood of acute cholecystitis. So this is specifically for our subset of patients, but we found this to be, this was the best way we could do to analyze and support the use of this clinical score to determine if there's a higher likelihood of acute cholecystitis. So in the end, this is really preliminary, but we want to make a second phase of our study. We want to take patients that we assess them, and we have the high suspicion that they have acute cholecystitis. Then if the patient has either 2 or the 3 factors, or a score greater than 2.5, these patients we believe should have a high probability for acute cholecystitis. And here we want to use the HIDA scan, which we have available in our institution, to confirm the diagnosis of acute cholecystitis. If the HIDA scan comes back that we have acute cholecystitis, these patients, in the end, we want to take them for an urgent cholecystectomy. If the HIDA scan comes back with biliary dyskinesia or chronic cholecystitis, well, we need to reassess this patient. We need to evaluate in the end, they're going to need a cholecystectomy, but we can decide if it's non-urgent or how we move the patient accordingly. And then if it's a normal study, what we need to do is consider another diagnosis, because most likely the diagnosis of acute cholecystitis is not present. The limitations of our study: this is a single center study. It's a retrospective review. We looked at our past data, a relatively small sample size, and then I found one paper that was very similar to our study, that they blinded. They not only took the preliminary pathology reports that they from the operations. They went back, found a pathologist, they blinded the pathologist, and he reviewed the pathology again, and that had a tendency to change the pathology report, and inflammation was found in more patients. So in conclusion, the HIDA scan is superior to ultrasound as a diagnostic tool in the setting of acute cholecystitis. Our current protocol of delayed scanning is associated with increased total time to surgery, length of stay, and overall cost. Risk factors associated with acute cholecystitis and or conversion to open technique included white blood cell count, elevated glucose, and age greater than 50, which was interesting, was consistent with literature. And then early employment of HIDA scan in high probability patients will effectively hasten the diagnosis and treatment. And then what we expect is we're going to improve outcomes and reduce cost. And then obviously this was our small review. This was retrospective. Now we need to, our second phase is to make this a prospective trial, which will help us support not only our high risk score, but early employment of the HIDA scan. That's it. Nice study.
Thank you very much. It was good talk about acute cholecystitis, which was the main topic of the day today. And questions welcome from the audience.
Thank you. And I think significant history is very important before you taking the HIDA scan.
Excuse me, I didn't understand.
Because the patient will be presenting with the first episode, and after HIDA scan you will say that it will go for chronic cholecystitis. So initially patient may not tell that the presenting symptoms will be late now. That's why previously they have done suffered with the pain, similar episode. After that they have been conservatively managed, and then they'll go for.
Well, I understand that in the setting of acute cholecystitis, we need to determine, we really need to clinically work up the patient completely. We need to get a complete history of physical. We need to consider if this is their first or second episode.
This is important, I guess.
Yes, sir. I agree with you.
Next question.
Thank you, Doctor, for a nice presentation. I have noticed that the conversion rate, you said, in the cholecystitis is 80% above, something like that.
No, the conversion rate was 18%. And of the 18? No, 18% the patient underwent open, and then of those 18, of the 18%, or 15 out of 21 of those patients were conversions. Yes, sir.
Yeah, and what is the percentage of conversion to open in cholecystitis?
What is the rate of conversion?
Yeah.
Anywhere to 5 to 10% from what I.
5%.
5 to 10% from what I saw in the literature.
Okay. Apparently there was a mistake on the slide. There was open cholecystectomies were in 82%.
No. I think that what you want to see here is this. So 82% of our patients who underwent laparoscopic cholecystectomy.
Laparoscopic is 18% with the blue.
That's an error. That's an error.
So that's the confusing.
So laparoscopic technique, 82% of the patients underwent laparoscopic cholecystectomy. And then 18% of the patients underwent open technique. So I just accidentally switched it. 82% of the patients underwent laparoscopic cholecystectomy. 18% went open. And of the patients that went, of this small segment, 15 out of the 21 patients were laparoscopic converted to open.
Okay, so it's just the slide.
It was just a slide that was yes.
Any more questions?
Any more questions?
I've got questions too, myself. So first, glucose level, is it pre-op, post-op level, and fasting, random glucose? Why did you pick up glucose level?
This is the preclinical assessment. This is in the emergency room, the way that they present, and the first glucose that they've measured.
Since the admission, they are fasting, and you're measuring glucose level once, twice, or how do you?
For the most part, once we've admitted the patient, we usually, in the first 24 to 48 hours, we measure it every 8 hours in these patients. But this particular number was in pre-admission, the first laboratories that were.
So it's the first number which you're taking?
Yes, that was the first number.
Okay, thank you. And is HIDA scan already available in majority of American hospitals, or is it?
Well, HIDA scan, from my understanding, is not readily available in every center, but in major centers it's available. And in our center we have it readily available.
Definition of delayed HIDA scan. What is this time frame you're looking at?
So the delayed HIDA scan was the protocol that we use is that we admit the patient, and then the patient, we wait for the HIDA scan for the nuclear team to come in to be able to employ the HIDA scan. And in general, what we found, it took on average for all the patients about 1.5 days to perform the HIDA scan, give or take. And so the delay, the reason I use delay is because we admit the patient and we wait for the HIDA scan, and then the patient has to wait, and then that can prolong the care.
Versus immediately done.
Huh?
Versus
immediately done, where we're now looking and reviewing the literature. We want to confirm the diagnosis, and we have this test available. What we want to do is that in the ER setting, be able to perform the HIDA scan, order the HIDA scan when in a high-risk probability group, and then if we can confirm the diagnosis, that's where we can move the patient to OR faster.
So I suppose a radiologist is not around the clock all the day long, who is able to perform HIDA scan.
Yes, but for the second phase of our study, and seeing the results that we've produced, the team we're making a multidisciplinary team, and the nuclear medicine doctor is on board to make this a 24-hour available technique that he can read the technique because it's not usual that he'll have to read it. It's not every day. So if he's on board to do this 24 hours a day for 7 days a week.
And what's the cost of HIDA scan?
The HIDA scan, give or take, is anywhere from $200 to $300. On the weekends, the cost increases because you have to wait for the nuclear tracer to be able to come in and have it available. So the cost is anywhere from $200 to $300.
So it's not the cost which is increased by the HIDA scan, which was twice as big as.
It was not that was one thing I really wanted to mention. It wasn't so much the cost of the HIDA scan, it was the delay. The patients were staying 2 to 3 extra days in the hospital with the delay, and then we take them to surgery. And so it's more of a to hasten the diagnosis, confirm the diagnosis, and move the patient. And we expect that the patient will behave more like a patient that we did an ultrasound, and we moved them to surgery pretty fast the next day without waiting.
Thank you. Does anyone have any questions?
We thank Dr. Rodriguez of St. Luke
Thank
Memorial
you.
Hospital in US.
Thank you.